Yeah, good evening, Shobha.
Good evening, madam.
Revati ma'am,
Hi, Ragini.
Good
Hi,
evening, Shobha.
Sudha.
Your video is not on.
Yeah, it is on, madam. One is on, one is not on. I'm
Uh,
logged in from two devices.
Oh.
Hello,
And
hi Maninder, hi Sudha.
hi.
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 everyone.
Shobha, you are
Yeah.
muted.
नहीं
Vipassana,
हाँ कर लेती हूँ.
Ragini,
Maninder ma'am, good evening.
Hi.
Hello
Gayatri.
Maninder.
Hi, Lakshmi.
Yeah, hi.
मनिंदर प्रिवेंशन ऑस्टियोपोरोसिस प्रिवेंशन के लिए कौन सा एक्सरसाइज सबसे अच्छा है?
उसके लिए सारी गाइडलाइंस आ गई हैं. For those above 60 years of age, those below 60 years of age, those have osteoporosis, for them also the guidelines are there. Exercises are same, the only thing is intensity is changed.
Hmm.
Duration, intensity of the exercise is changed. Hi,
All cannot do all.
Sudha.
Hmm.
Sudha,
Namaskar.
namaskar.
Dr. Maninder can do every exercise.
Hi, Sudha ji.
Hello, namaskar. Change the name.
किया मुझे तो ये एड्स ने बड़ा तंग किया फोन में.
वो क्लिनिक का फोन है ना.
Dr. Ragini change.
हाँ, क्लिनिक का है ना एक्चुअली.
रागिनी जी, we should start sharp.
yes
कर रही हूँ, नाम चेंज कर रही हूँ.
No, we will start now.
yeah because
2
we
minutes to
Yes,
go.
of course.
2 minutes to go.
शुरू कीजिए.
Now we are
Yeah.
live on YouTube, ma'am.
Hmm.
Where is the link, Paresh? It's all in the groups.
Yeah.
పంపిస్తారా పైకి నేను లైబ్రరీలో ఉన్నాను.
It's come in this group also.
Dr. Padmaja, is your WhatsApp being hacked?
Yes,
You know, I
madam. Yes,
Yeah,
madam.
I got a message from your to deposit. I know how much amount in your bank.
No, madam, that is the least of the problems. Most of the people who know me know that I don't send random hi, hello. They know that I use the phone so infrequently that anyone knows something needs to be done, they'll give a call to my husband. But after the phone was hacked and we managed to get it out, now my WhatsApp is crashing every time I try to connect it on the computer. So we are in the middle of a conference, all messages are on WhatsApp, everything is going off. So it's like a fresh new start every day. That is the biggest problem.
And they had sent me the link also to deposit some money.
Yes.
That I think that
It
Sudha,
has become
I
very
think
scary
everybody is.
now.
Why my video is stopped? I can't switch on my video.
Hi, Dr. Anju. Good evening.
Good evening, but I can't switch on my video. I don't know what is the problem.
Yeah.
Go out and again log in.
Technical team to help.
Just go, leave the meeting and again join.
अच्छा करती हूँ, okay जी.
So this time, like this rural committee work which Dr. Mohinder had said, we started working
now
on it.
it is
Now
fine.
everything is gone again. Every day,
Correct.
getting,
I think Padmaja, we will start.
Yes,
Lakshmi, can you start, please?
Yeah, yeah.
Lakshmi.
Yeah.
So good afternoon, everyone, and now you can
Good
start.
afternoon.
Yeah.
Yes,
Good
good
afternoon. Respected dignitaries, esteemed faculty for the day, and delegates, a very good evening to one and all. With increasing lifespan of a woman, a good number of women spend more than 1/3 of their life post-menopause. So it's very important to educate not just the gynecologists, but physicians in general, the importance of prescribing in menopause because we aim at a holistic health for our women. Thanks to the enormous work by Indian Menopause Society, menopausal medicine, if we can call it so, is gradually percolating into the fraternity. This wonderful initiative of prescription e-workshop was the brainchild of Dr. Anita Shah, our president, Dr. Ragini Agarwal, Dr. Shobha Gudi, along with co-directors and coordinators. Briefly about this module, for those who have not attended the first one, this is the second of a series of 8 modules that have been created for prescription writing in menopause and will be scheduled for the first Wednesday of every month till December 3rd. Today is our second module and the theme is bone health. Welcome you all to this wonderful episode of Prescription e-workshop. At the outset, I would like to invite our esteemed President of Indian Menopause Society, Dr. Anita Shah, to give her presidential address. Over to you, ma'am.
Thank you very much, dear Lakshmi, for your kind words. And thanks a lot to Dr. Ragini and Dr. Shobha for planning this e-prescription workshop. And I am sure that during last module, everyone must have enjoyed it, and a lot of carry home messages must have got it. Today's module is also very, very important regarding bone health. As we all know that our slogan of Indian Menopause Society is only fit at 40, strong at 60 and independent at 80. And for that, bone health is really very, very important. Without wasting much time, we all know that osteoporosis is a silent killer, and a lot many cases of osteoporosis are diagnosed, and we have to spread this awareness in our midlife women so that they can take in priority, they can give take care of their bones. एक्चुअली हम लोग ऐसा कहते हैं ना कि हम जैसे LIC का प्रीमियम भरते हैं ताकि हम जब बूढ़े हो जाए तो उसका हमको एडवांटेज मिले. सिमिलरली वी ऑल्सो हैव टू टीच अवर वीमेन that from adolescence we have to start take care of bones. But regarding this bone health and prescription writing for osteoporosis, we have today's module is very, very important, and all the speakers, Dr. Ragini, Dr. Sudha, Dr. Padmaja, Dr. Jyoti Bhaskar, everyone will give a lot of carry home messages, and they will put they will give good inputs regarding the subject. So let us start our today's module. Thank you, Lakshmi, again.
Thank you, ma'am. Now to speak on to start off the CME, may I now invite our first speaker of the day, Dr. Ragini Agarwal, who's also the Secretary General of Indian Menopause Society, for her talk on the impact of perimenopause and menopause on bone health. Over to you, Ragini, ma'am.
Okay. Thank you so much, Dr. Lakshmi. Yeah, we are going to start. Just give me a 1 minute.
Now, to briefly introduce ma'am, she's, as I mentioned, she's the Secretary General of Indian Menopause Society, a pioneer of cosmetic gynecology. As you can see, she has several awards and publications to her credit, and a thorough academician that she is. Over to you, ma'am.
Thank you so much. Just let me share my screen.
Okay, so I'll stop sharing.
Just share. Okay. Share. So very good evening to one and all. And thank you so much for joining this program, which is a very, very important thing. We should know how to prescribe exact and proper and optimize our prescription for the menopausal woman. So today's topic is on the bone health, and we all know that it is a very important thing to understand the bone health and how to give a prescription for the bone health to all of us, all of our patients. So today my topic is bone health in perimenopause and menopause. We all know it is a silent thief of strength. So with blessing of God and gratitude to all, I'll start my presentation that osteoporosis, which predominantly occurs in females, we all know it is one of the most common consequences of menopause and is characterized by bone loss and microarchitectural degradation, which leads for fractures, pain, and immobility. Conventional treatment for osteoporosis target bone loss by inhibiting osteoclast activity, but these only prevent osteoporotic fractures in 50% of the sufferers. An advanced understanding of the underlying mechanism and treatments for the osteoporosis is required to avert the projected trend, and whereby the worldwide economic burden of the treatment will reach many billions by 2050. So there's certain thing which we have to understand when we talk about the osteoporosis with our patient. One thing which is very important is the peak bone mass, which is achieved at 30 and largely influenced by genetics, nutrition, and physical activity. So we have to catch them young and tell a youngster that they have to have their bank balance by younger age. Only then they can have a benefit in terms of the bone mineralization and the bone strength in the older age. The stable phase is through early adulthood, that is 30 to 40 years. And then the moment the transition starts, the bone loss accelerate, especially first 5 to 10 years post-menopause. Average woman loses up to 20% of her bone mass in 5 to 7 years after menopause. So estrogen is the thing. Whenever we talk about the menopause, it inhibits osteoclasts, thus reducing bone resorption, support osteoblast activity, promoting bone formation, and maintain the balance in the bone remodeling cycle. With estrogen withdrawal, bone turnover increases, favoring reabsorption over formation. So not only this, there's a receptor activator nuclear factor K-binding ligand is protein that stimulate the differentiation and the activation of the osteoclast and which is responsible for the bone reabsorption. So estrogen through its receptor can directly regulate the expression of both OPG and RK in osteoclast. So estrogen deficiency play a very, very big role in this osteopenia and osteoporosis, although we know it very well, but how it has to be clear in our mind. So perimenopause, there's a fluctuating estrogen and the progesterone irregular cycles, and we all know what is menopause. So in menopause estrogen deficiency, there is a decreased apoptosis and increased RK and KL differentiation, so increased net bone resorption. And when we talk about the osteoblast, there is a decreased net bone formation. And in osteocytes, again, apoptosis increase, leading to activation of the bone remodeling. So there's a temporal relationship between the hormonal changes and the bone loss. And most of the damage occurs before woman even realizes that she is postmenopausal. That's why we call menopausal transition as a preventive time for a postmenopausal woman. And we have to put lots of stress at that period when she is going under the transition. So hormonal trigger are estrogen deficiency leads to upregulation of the RA and KL, promoting osteoclast, reduce osteoporotism, and osteoblast activity cannot match the pace of reabsorption and leading to net bone loss, particularly in a trabecular bone. Up to 2 to 5% bone loss per year in the first 5 to 7 years after menopause, and trabecular bone loss precede cortical bone loss, and by age 65, average woman has lost 25 to 30% of the bone mass since peak. Importance of early intervention during perimenopause is really a very important factor. So, what is the hidden risk? Bone loss begins before cessation of menses. Women may appear clinically normal. Trabecular bone especially vulnerable due to higher turnover. And it is a really missed opportunity if we don't focus at this age, because then we are waiting for what? The silent fractures. So encourage proactive screening and lifestyle advice, even in women who are still menstruating but symptomatic. I think dance is a very good answer. So what is osteoporosis versus osteopenia? We have to define this spectrum. We all know that the DEXA scan is the gold standard, and what is normal if the T score is more than -1, and between -1 to -2.5 is osteopenia, and if it is osteoporosis, T is even less than -2.5. So osteopenia is not benign. This is the time when you have to be alert. It is like pre-diabetic condition. There's increased fracture risk is still present. And Z score for younger and postmenopausal patient with the risk factor. So what are the clinical phase of bone loss? Spine, hip, and distal radius are most common. Vertebral fractures are often silent, only detected on imaging. That's why many a time you see the it start decreasing. And hip fractures have high morbidity and the mortality, 20% in first year post fracture. So timely detection is very important. Screen all women more than 65 years and younger with risk factor, including history of fragility fracture, family history of osteoporosis or hip fracture, low body weight, smoking, alcohol, chronic corticosteroid use, early menopause, and rheumatoid arthritis or other secondary causes. So this is very important to understand the bone health across the lifespan. Calcium intake, vitamin D status, physical exercise, and level of the D intake. So bone densitometry is the cornerstone. Understanding of the DEXA scan is very necessary when we say normal osteopenia, osteoporosis, or the severe osteoporosis. Other tools are FRAX tool, trabecular bone scoring, quantitative ultrasound, and a very good score. This Oster score is a very good thing. It is, you can keep these things on your table. You do need not to send the patient to anywhere. And if patient is coming in the low category, maybe you don't require to go with a DEXA scan. So management strategy, I'm not going to take because it is going to be discussed. Lifestyle modification, role of hormone therapy, non-hormonal pharmacological option, timing of intervention, special consideration like cancer survivors, early menopause, and the surgical menopause, where we are really going to address a severe form of the problem. So OBGYN and the bone health mandate is very important. We see movement in perimenopause and early menopause is a key time to screen, encourage calcium and vitamin D intake, weight-bearing exercise, smoking and alcohol sedation, initiate early screening, specifically women with the family history and menstrual irregularity. So putting it all together, the key pearls are bone loss begins in perimenopause, estrogen deficiency is the central point, use risk-based screening, DEXA, FRAX plus clinical judgment guide the treatment, OBGYN must champion bone health during menopause consult. So preventing one fracture can change the trajectory of a woman's aging. Keep your skeleton happy and healthy. Thank you so much for your patience.
Yeah.
Thank you, ma'am. Okay.
Yeah, Dr. Lakshmi.
Yeah.
I think one thing which we must bring in now is to take some expert comments from the past presidents who have joined.
Yeah.
And I can see.
Anju ma'am is here. Dr.
Yeah. Is others who are Dr. Maninder is there.
Yeah, Dr. Maninder ma'am.
And Dr. Anju is there, and I think one
Of
more
course.
person I saw. Ambuja madam has joined? No, not yet.
Vipasa
Okay.
ma'am, you know.
Yeah.
Linda
So-
ma'am, could you please give your comments on
Yeah, I think
this topic?
congratulations, I think first to Anita Shah, team, Dr. Ragini Agarwal, Shobha Gudi for taking this effort. Because I think this is one of the most neglected topics, still we gynecologists feel that we are not supposed to treat it. We are just talking about it, but none of us is actually diagnosing and treating it. That is what I think we should be starting. And I think Sudha Sharma from next year, we should take it on a bar footing, the treatment of the management of the osteoporosis by the gynecologist. And this year, Anita Shah is starting it. So we have to diagnose it. Yes, as Ragini said, the main prevention starts from the adolescence. She's very right. The actually peak bone mass starts increasing along with the height velocity. When the kids, they start gaining their height before onset of puberty. So that is the time when they should be doing maximum exercises, maximum calcium take, protein intake, and group activities, especially jumping exercises and all that group, basketball, lawn tennis, throw ball, everything which can be a jumping exercise. And that should be that, because that jumping exercise increases 3 times the weight of your body on your joints. So that builds up the bone mass. So, and it goes on till the age of puberty, and a couple of years beyond that, then there is a plateau, and then mid-40s, it starts coming down first at the rate of 1 to 2%, and then 5 to 6% beyond the age of menopause. So she has very rightly said that this is the point when we should be doing. And at the problem is that at that point, our kids are busy preparing for their NEET examination, for their university examination. Somehow or the other, we all should endeavor to increase these activities. If we want to make them healthy, these group activities should be there. Even in my grandson, I am finding a difficulty because the group activities are now sort of, they're sending them to classes, paid classes. We had the open grounds with the, we had lots of these activities. So what I'm advising, at least for the girls, is skipping. Skipping, which can be done at home only, and 50 to 100 schemes are best, and they can be done in the slum areas, in the buildings, in your own bedrooms and everything. I think the least we can advise is this, and then schools should see to it that at least 1 hour of high impact exercises are given to all these kids who starts from 10, 11, 12 years of age to till the time they are school, and then when they go college, so they become a different class altogether. Congratulations, Ragini, for covering it so nicely, because let's other speakers come and other presidents also contribute something.
Yeah.
Very
Anjuma,
well
would you
said,
want
Dr.
to add something?
Very well added, Dr. Maninder. I think the importance of exercise cannot be emphasized enough. I mean, it really needs to be emphasized, because nowadays the children have become a potato coach and they don't do any kind of exercise. I totally agree with you. Doing skipping is very good, but most of the time they avoid skipping. Swimming is one exercise which can be included for everyone, for every age also. Because even if you can't swim, even if when you walk in the water, that is very good for your joints and also for your bones. So in this weather, I suggest for all of us to go for swimming and walk in the waters. That will really do a lot of help to all of you. And it is definitely a silent killer, and we must work, all of us, to bring in awareness, because that is what is most required. You know, everybody thinks मेरी bones को तो कुछ नहीं हो सकता, मेरे को क्या problem हो सकती है. That is what is the biggest myth, and that needs to be addressed by us ourselves only. So that is very important thing. And today I want to suggest that all of us who are sitting here must get their BMD done in this month only, and then reanalyze your own health. So that is what will give us the insight that how important it is to look after your own health.
Thank you,
The
ma'am.
sooner we do, sooner we
Okay.
do, the more better it is.
Thank you very much for your comments. I think we'll now move on to the next speaker. May I now invite Dr. Sudha Sharma, who will be talking to us on critical analysis of evidence for MHT in prevention of osteoporosis. So to briefly introduce Dr. Sudha ma'am.
I think we can move
Yeah,
ahead.
Madam is a former professor of Government Medical College, Jammu and Kashmir. She is also the president-elect of Indian Menopause Society 25-26. She was a vice president of Indian Menopause Society 24.
That's fine, Dr. Lakshmi.
25.
Much more importantly, Dr. Sudha Sharma is the now the president-elect. So
is it seen, ma'am? Is the screen seen?
Yeah. Thank you.
Sorry
Thank
for the
you
delay. Extremely sorry for the delay.
So thank you for your kind introduction, Dr. Lakshmi. I would now start sharing my screen. So at the outset, I really want to congratulate Dr. Anita Shah, Dr. Ragini Agarwal, the brain behind both of them. Then Dr. Shobha Gudi, Dr. Lakshmi, course co-directors, and all the coordinators for taking up this initiative, and thank you for giving me the opportunity. Can you see my screen?
Yes, you are visible.
Okay, so my this heading is not matching with the one which is being read. I think Dr. Shobha will tell all of us. So estrogens and bone health. I think a lot has been said by Dr. Ragini. Wonderful presentation. So I just want to highlight few things that, bone remodeling or bone metabolism is a lifelong process where mature bone tissue is removed. Bone resorption, that is the, process, and a new bone form is being formed, bone formation or ossification. We all know it. Estrogen is the major hormonal regulator of bone metabolism, and it is interesting to unravel the pathways by which it exerts its protective effect on the bone. Considerable clinical and basic research now has established that estrogen is perhaps the major systemic regulator of bone metabolism, not only in women, but also in men. So in order to maintain the structural integrity, the skeleton needs to, remodel and repair the microcracks that develop both in cancellous as well as in the cortical bone. And this remodeling process occurs in basic multicellular units that would include all the elements of osteoclast, osteoblast, osteocytes within the bone remodeling cavity, which is covered by a canopy of cells known as bone lining cells that form the bone remodeling unit. And in turn, these bone lining cells, they are in communication with the osteoblasts, which are embedded within the bone matrix. Now, to show this, see, this bone remodeling compartment, it comprises the cell which constitutes the basic modeling unit. See, these are the osteoclasts, these are the osteoblasts, we have the osteocytes, then these are the bone lining cells, and we have marrow capillary also. No, there are connections between these osteocyte networks, surface bone lining cells. All these cells in this network, they are connected with gap junctions, which we can see, which might provide a pathway by which the signals, they are generated. See, here in this, the signals are generated. They are, carried away by the osteocytes deep within the bone. Then they reach the surface and they elicit remodeling events by osteoclasts. These are the osteoclasts and these are the osteoblasts. So osteocytes, they play a key role in controlling the bone remodeling. When they, see the mechanical strain because of the deficiency of the estrogen, they are able to trigger this bone remodeling. So estrogen has been shown to inhibit osteoblast apoptosis, and increases the osteoblast's lifespan. Now, this is the effect of the estrogen through the osteocytes, activation of bone remodeling, through the osteoblasts by different mechanism, maintenance of bone formation, through the T cells and osteoclasts, there is bone resorption. Now, what is the role of menopausal hormonal therapy? Estrogen progesterone therapy, or EPT, may prevent and treat the osteoporosis in the early postmenopausal symptomatic women unless it is contraindicated. It prevents all osteoporotic fractures, even in low-risk population. It increases the lumbar spine BMD up to 7.6%, femoral neck BMD up to 4.5% when used over 3 years. Also reduces the risk of spine, hip, and other osteoporotic fractures by 33 to 40% nearly. That is grade A evidence. But before prescribing, a thorough pre-treatment and annual follow-ups are crucial. Dosage and duration should be personalized and reassessed annually based on a risk-benefit analysis. Why hormonal therapy should not be the solely initiation for bone protection after a decade of menopause? Extended use can be considered carefully, weighing the risk and the benefits. But one thing we all should remember, the bone protective effect disappears when hormonal therapy is stopped. That is grade B evidence. And these are, the estrogens and the progestogens and tibolone, which we normally give in hormonal therapy. Tibolone is a selective tissue estrogenic activity regulator. We all know with, all three effects, estrogenic, progesterogenic, and androgenic. With its estrogenic impact on the bones and the inhibition of osteoclastic activity, it is approved for alleviating vasomotor symptoms in 90 countries and preventing osteoporosis in 45 countries, typically prescribed 1 year after amenorrhea. Demonstrating effectiveness, it addresses vasomotor symptoms, improves urogenital atrophy, that is grade A evidence, enhances libido, grade B, but is contraindicated in individuals with strong stroke risk factors, breast cancer survivors, and women beyond 60 years, that is grade A evidence. We need to remember that. Now, the standard tibolone dose is 2.5, but low dose of 1.25 milligram proves equally effective for various indications, including osteoporosis. It reduces the risk of vertebral and non-vertebral fractures in older osteoporotic women, preventing bone loss at a level which is comparable to standard doses of conventional menopausal hormonal therapy. Also significantly increases lumbar spine and total hip BMD when it is compared to raloxifene, again level A, grade A evidence. Now, what are the various recommendations and the guidelines for menopausal hormonal therapy in osteoporosis? Several international guidelines endorse MHT as a potential first-line therapy to maintain bone health in women just entering menopause. This is the European Menopause and Andropause Society says that administration of systemic MHT poses a favorable risk-benefit profile for women under 60 within 10 years postmenopausal for both menopausal symptoms and osteoporosis. So, keep in mind for both menopausal symptoms and osteoporosis. North American Menopause Society asserts that the benefit over ratio is optimal for treating prominent vasomotor symptoms and for women under 60 within 10 years of menopause, especially those at high risk for bone loss or fractures and with no, contraindication. Recommendations from the International Menopause Society also says the same. American Association of Clinical Endocrinologists highlights MHT should be administered at the lowest dose and shortest duration needed to manage menopausal symptoms. They also stress its use for osteoporosis prevention and fracture treatment within an overall benefit versus risk assessment for each patient. We have US Endocrine Society, that says that there is lack of consensus regarding efficacy of menopausal hormonal therapy in preventing cardiovascular disease, breast cancer, or dementia. But this society also acknowledges its uncertain benefit in fracture prevention. ACOG emphasizes treating menopausal symptoms, advocating for the lowest dose and shortest duration. So a global consensus statement 2016 states that MHT can be commenced in postmenopausal females at risk of fractures or osteoporosis risk before the age of 60 within 10 years. Now, this sentiment was backed by prominent organizations all over the world. Endocrine Society 2019 have recently released comprehensive guidelines for categorizing and evaluating individuals at low, high, and very high risk of osteoporosis fractures. So MHT to be used in what they say lowest effective dose for prevention of all types of fractures in young less than 60 postmenopausal females at high risk of fractures with bothersome vasomotor symptoms without any contraindication, and those in whom other therapies like bisphosphonates or denosumab are not appropriate. Our own Indian Menopause Society guidelines. MHT is the appropriate therapy for women under 60 with an increased risk of fractures, not recommended after 60 for sole purpose of osteoporosis prevention. But clear guidelines regarding when MHT might be indicated to prevent osteoporosis in asymptomatic women were found lacking. It might be considered a preventive measure in the initial phase, especially in situations where targeted bone therapy might not be appropriate. But we have limitations. While beneficial for some individuals, it comes with several limitations. Side effects are there which affect the quality of life. It might not be suitable for all the individuals, especially with history of certain type of malignancies, strokes or liver disease, wherein it is contraindicated. Associated with an increased risk of serious health issues also only with prolonged use. And this necessitates careful consideration and ongoing monitoring during the treatment process. Furthermore, the beneficial effect often reverse. We need to keep this in mind once the menopausal hormonal therapy is halted. There is also the challenge of adherence to the therapy. So it is essential to have a thorough discussion with healthcare providers to understand the potential risk and benefits fully and to ensure informed decision-making regarding the therapy. So currently, MHT is the only anti-osteoporotic treatment with proven efficacy in reducing the risk of fractures in early postmenopausal women with a low to moderate fracture risk. The only caveat is the lack of certainty regarding the anti-fracture efficacy of low-dose estrogens, as definitive fracture outcome data are scarce. It is also not clear whether the route of administration might impact the anti-fracture efficacy of estrogens, although the bone data suggests that there is some evidence of a persisting benefit on total fractures amongst former MHT users. The protective effect may be somewhat lost 5 years after cessation of treatment. Even though bone loss rates, according to few studies which I have given below, even though bone loss rates tend to revert to typically postmenopausal levels after discontinuing MHT, women previously treated with MHT were reported to maintain higher BMD for many years post-treatment when they were compared to those who had received placebo. For early postmenopausal women with a low to moderate risk of fractures in the next decade, MHT offers a valuable preventive treatment option. It prevents osteoporosis regardless of initial BMD level. It reduces the fracture risk. Long-term MHT use is linked to a reduction in the risk of fractures, particularly hip and vertebral fractures, providing a potential preventive strategy for osteoporosis. Demonstrates a favorable balance of risk and benefit for symptomatic early postmenopausal females, again below 60, less than 10 years, and based on effectiveness, cost and safety, MHT should be considered as a first option for the maintenance of bone health in these women with a low to moderate risk of fractures, where specific bone active medications are not warranted, and where the females are suffering from strong vasomotor symptoms. The individual benefit risk balance is dependent on whether it is opposed or unopposed, whether you are giving with progesterone or without progesterone, what type, dose, and route and duration, together with the individual risk profile. Emerging research highlights the need for personalized MHT strategies, taking into account individual risk profiles and health history for optimizing therapeutic outcomes. So, proactive, preventive, and management of osteoporosis, menopausal practitioners will make significant impact on morbidity and mortality in menopausal females. Thank you. Thank you very much.
Thank you, Sudha ma'am, for that very clear and precise message on the role of MHT in osteoporosis. May I now invite comments from the experts, if any?
I think Sudha has covered very nicely the role of MHT. Though personally, Sudha, I am always thinking that we are still reserved about the use of MHT. We are still very reserved, though the international guidelines now they have come up that if the
Yes.
patient is benefiting from that, with the patient's consent, you can continue for a longer time also. So
True.
that giving for the shorter time is, I think, no hold. We should not be always scared when we are following up the patient and we know that she's not having any side effects. We are doing her repeated mammography. That is the basic cover. And there is no family history of breast cancer anywhere. And patient didn't have any breast cancer risk. So we should not be always scared of the basic risk which is there. So that basic risk has to be explained to the patient as compared to the relative risk. So what is the absolute risk which is going to cases which are going to occur? So those things are very important when we are counseling the patient, that they should not be scared. Why they should not be scared? Because this is the basic. Even when we are not giving MHT, breast cancer is occurring. So
Yes.
how many cancers are asking when we are not giving MHT? That is one thing. Secondly, we are not talking about other treatment, but I can just go for 1 minute offline because I read something very, very interesting recently in Menopause Live. That was the last newsletter only there. So there they are doing the journal scans and everything. So they say zoledronic acid, because bisphosphonates we can combine with estrogens also. And when after 2 years we see that the bone BMD is not increasing, decreasing, at that time we can add the zoledronic acid.
Yeah, correct.
And now they have tried the zoledronic acid in a new dose schedule. Just give for 1 dose and second dose after 5 years. And they have found the fracture risk reduction. That
Yeah.
whole paper is there with me. I can share with
Yeah.
you later on. But that makes it so easy for us to take that zoledronic acid, where we are always scared we should be taking or not. And they have given in osteopenia cases, not osteoporotic. Why they are giving in osteopenia? Because the number of patients who are there in osteopenia are much more than osteoporosis, number one. And if we don't treat them, they will land up in osteoporosis. We just don't have to wait for them to go into the osteoporosis to treat them. So that is
Correct.
very beautiful paper which has come
Yeah.
out now, zoledronic acid, just
Mhm.
2 doses. And they have compared with placebo, and they have
Mhm.
compared with zoledronic acid, placebo, and zoledronic acid with zoledronic acid at 5 years. All 3 schedules they have compared very
Yeah.
nicely.
Thank you so much, Maninder ji. Lakshmi,
Thank
just
you.
1 minute and
Yeah.
then we can start Dr. Jyoti Bhaskar's talk, please. I just wanted to thank Maninder ji for bringing in this wonderful input of bisphosphonates use in osteopenic women who are even premenopausal. So we will be, I'm sure we have an endocrinologist and orthopedician who will briefly join us now. Dr. Anita's
So,
resource
yeah.
faculty after Dr. Jyoti Bhaskar's
Yeah.
talk. And there is this bisphosphonate will feature in our prescription accordingly. So thank you, Maninder. That is the latest thought that not very latest, actually, it has been there
Not
for some years now, that
peripheral.
younger women with high risk of osteoporosis
Yes.
can be considered for bisphosphonate therapy, and the tolerance is better more during the prescription hour. Thank you so much, Maninder. Please go ahead with
Okay. Thank
Jyoti
you,
Bhaskar.
Maninder ma'am, and thank you,
Jyoti
Dr.
Bhaskar.
Shubha.
Yeah.
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 May I now invite our next speaker, Dr. Jyoti Bhaskar, for her talk on assessment of bone health for women in midlife. When to start, which one, and how often? Dr. Jyoti is Secretary, Delhi Menopause Society. Over to you, ma'am.
Thank you so much. And I would, at the outset, like to thank Dr. Anita Shah, Dr. Ragini, Dr. Shobha, and all the stalwarts over here to give me this opportunity to be able to deliver this talk. I think Dr. Ragini has already set the tone about the assessment, but I will just go a little more into the detail. And the first and most important is, when should we start screening? Now, with our Indian Menopause Society guidelines, it is said asymptomatic women, we should do opportunistic screening, which means that if a patient has come into a OPD, whether she's come for AUB, whether she's come for any other kind of problem, we should take that opportunity to be able to screen her for osteoporosis or bone health. And it's a very simple screening. We need to take a detailed history, do a physical examination, and use the various assessment scores that we have, and that will do the initial evaluation of osteoporosis. Now, in the history, what are the things that we really need to look at or ask? The major risk factors. Advancing age by itself is a risk factor. If they're 40, 50, 60, as the age advances, the risk for the bone health being not very good, osteoporosis increases. Low body mass index. I really felt good when I read this, that all of us who are obese and a high body mass index, at least in one area, we are very well saved, and that is as far as the bone health is concerned. We need to take the prior history of fractures, especially the fragility fractures, not only in that particular woman, but also parental history. Smoking. All the girls, many of them nowadays are smoking, so we should not hesitate in asking for this. Alcohol intake, at least more than 2 drinks per day. If for any reason they've been on glucocorticoids for 3 months, history of rheumatoid arthritis, and of course the race and ethnicity. But here I would also like that it's important also to look at the modifiable risk factors, because these are things that we can change, control, and improve the bone health. That is, look at the nutritional status, spend some time with the patient, ask her what she's consuming, how much of proteins, how much of calcium intake is there daily, whether she's vitamin D deficient, that we can find out by doing the blood test. What is her lifestyle? What is the lack of exercise? Is she just, as someone said, a Twitter couch? Or is this lady just doing walking? Is she going to the gym? Is she building up her muscles? What is her BMI? And of course, excessive intake, not just of alcohol and smoking, but even the caffeine and the salt intake. The next thing we also need to detail in the history is the risk factor of falls. When I was making it, I really thought we are talking about osteoporosis, the bone health. It tends to break when they tend to fall, but we need to understand, why do they fall? And the reason for their falling down as they tend to increase in age is because of the sarcopenia that tends to set in. We thus needs to ask them, what is the history of falls? Do they have any neurological disorders which lead for them to falling continuously? What about the vision? Are they able to hear very well? Is there proximal myopathy? Are they on some sort of medications? And what are the environmental factors? This also we should spend some time in asking them. After that, a basic physical examination. The height we always tend to measure, weight, calculate the BMI. Just make them walk, see what is the balance, what is the gait. A simple chair stand step, that is, get up and tell them to walk a few steps, turn and come back. Make them stand against the wall, see whether the WD, that is occiput wall distance, should be evaluated, and it should be 0. Put your 4 fingers between the rib and the lower iliac spine, whether we are able to do it or not, and whether they have kyphosis or Dowager's hum. Having done the basic history and the physical examination, then sitting in your OPD, we can do just and the commonest we can do is the OSTA, which is specifically for Asians, which is called the Osteoporosis Self-Assessment Tool. Even the WHO Fracture Risk Assessment, which you know as FRAX, is available on our phones. We can download it and calculate while the patient is sitting in front of us. A little about the OSTA score. This was developed by the WHO. It was aim of this particular score is to identify the women who are at risk of osteoporosis based on simply 2 factors, that's the age and the weight. It had been developed from data from about 860 women from 8 countries, which included Malaysia, the Korea, mainly the Southeast Asian countries. And the formula is extremely simple: 0.2 into weight in kg minus age in years. Based on this, we divide them either into low, intermediate, or the high risks. The ones who are at high risk, they are found to have 61% chance of having osteoporosis. The ones in the intermediate risk, about 15%, and the one in low risk has been found to be only 3%. The risk index has a very good sensitivity of 91%, though specificity is only 45%. Thus, this particular screening tool is extremely important to know that which patients in low resource countries, or even in our country, we would say, would be able to be sent for the BMT. So this is how the chart tends to show. And the basic, I would say, the interpretation would be, if the patient comes to be at high risk, we need to send them for BMT because 61% of them are likely to be osteoporotic. In case BMT is not available, we can consider starting them on drug treatment. If they fall into the moderate risk, it's about 15% chance of them having the osteoporosis. We still recommend them to have a BMD and consider drug treatment if BMD is low. For the low risk patients, we do not need to do BMD unless and until other high risk factors are present. When do we repeat this score? Normally, it's said that everything is going all right. You tend to repeat it after 5 years. But if there's a significant weight loss or if there's appearance of other high risk factors, then it needs to be done much more earlier than that. The second we talk about is the WHO Fracture Risk Assessment Tool, which is commonly known as FRAX, and we know it has been developed by the Shepherd University. It is country specific, though if we do it on our mobiles today, it does show that it is Indian specific too. But I would just say what the limitations are. It looks at age, gender, weight, height, and there are other 6 parameters that you can see on your screen, which needs to be fed. We may or may not have a BMD in these cases. Even without a BMD, it tends to give us a risk. The risk it gives is a hip fracture risk and the major osteoporotic risk. It is based on the US population that if your hip fracture risk is more than 3%, or your MOF is more than 20%, then the 10-year probability of having fracture is high. And it tells you that these are the ones that you need to undergo some interventions. Thus, putting it the FRAX test predicts the absolute risk of having fracture over the 10-year, and it is a cost-effective analysis of which patients need treatment and which will benefit from the particular treatment. What are the limitations? As far as Indian population is concerned, if you look at those parameters, it does not take into the nutritional status. Our Indian population, the nutritional status has been found to be less, so we say it may not be very well validated, or we are likely to miss a huge chunk of women or the population who actually are at high risk of fractures. Secondly, as we all would agree, there's a lack of reliable data within our own country. So we alone cannot depend upon the FRAX score. We have to use it along with our clinical judgment when making decisions for the management of these patients. Now, coming on to the BMD or the DEXA scan that has been done, this I've picked up from our own IMS guidelines of 2020. Who are the patients who need a BMD? And as a gynecologist or the menopausal practitioner, whom are the ones you're going to send for a BMD? All postmenopausal women more than 5 years of menopause. If they're less than 5 years, if they have any of the high-risk factors that I have already enumerated, women in menopause transition with secondary causes, if there's a radiological evidence of osteopenia or presence of vertebral compression fractures, women with fragility fractures which have just been diagnosed in radiology, or before initiating pharmacotherapy for osteoporosis. When we talk about sarcopenia, BMD or DEXA scan plays an important role in assessing the skeletal mass also. We have other guidelines where the age to start tends to vary. Our own Indian Society for Bone and Muscle Health say that 60 years or older, regardless of risk factors. Rest of the international guidelines have used the cutoff as 65 years, even if there are no risk factors. Why are our guidelines different? Why are we saying that any postmenopausal women 5 years after that needs to be started? Because our age of menopause in our country is 46.7, which is 5 years earlier than any of the Caucasian countries. Our Indian women have 5 to 15% lower bone mass. The presentation of osteoporotic fractures occurs normally 10 to 15 years earlier than the Caucasians. The prevalence of low bone mass is 40% from the age of 40 years and nearly 80% from the age of 65 years, and nutritional poor nutritional status, and low BMI are contributing factors. Thus, in our context, for our Indian women, we would still go ahead with postmenopausal more than 5 years without any risk factors. We should start evaluating them by BMD. A little about the BMD. The DEXA scans look at total hip, femoral neck, and the lumbar spine. If these are not any one of these sites, we cannot. It's only then that the 1/3 of the radius is taken into it. The lowest BMD score among all the sites is mainly used for the diagnosis. When the initial diagnosis of osteoporosis has been made by the T-score, the diagnosis persists even when we do a repeat DEXA and we find that the score has become better. We need to repeat DEXA every 1 to 2 years till the findings are stable. And generally, it is recommended that repeat BMD should be done on the same machine and by the same technologist so as to be able to serially assess the effect of the osteoporotic therapy. The classification, normal if T-score is -1 or above, low bone mass osteopenia -1 to -2.5, osteoporosis if -2.5 or below, and it's considered to be severe if it's -2.5 or below, but with fragility fractures. But when we make a diagnosis of osteoporosis, it is not just on the BMD. So we know that if its score is below -2.5, it is definitely an osteoporotic in postmenopausal women. If she has had any low trauma, spine or hip fracture, regardless of BMD, she's considered to be osteoporotic. If the score is between -1 to -2.5, that is, she's osteopenic, but she has a fragility fracture, a proximal humerus, pelvis, or distal forearm. Again, she's treated as an osteoporotic. If the score is between -1 and -2.5, but the high frac score, again, she will be considered as a diagnosis of osteoporosis. Along with this, certain basic bone tests, that's laboratory tests, should be done to assess the bone health. That's a CBC with the ESR, serum creatinine, total protein and albumin, serum alkaline phosphatase, calcium and phosphorus, definitely a vitamin D, serum TSH, PTH levels if indicated, and X-ray in case we find there's a shortening of height or there's a problem, we need to do it. Of course, we need to also look for secondary osteoporosis causes, and that depends upon which disease we are suspecting. For myeloma, it's ESR and serum protein electrophoresis, LFT if you're looking at chronic liver diseases. Then we have also to look for the celiac disease, hypogonadism, Cushing's disease, and sometimes even diabetes. These need also to be identified. Then the question is, how often we do it? If everything is normal, or if she's found to be osteopenic, once every 2 to 5 years. Again, if there's excessive weight loss, if the high-risk factors tend to come up, it needs to be done much earlier. If the woman is on treatment for osteoporosis, then it has to be done every year with the same machine and preferably the same technology. Now, there's a risk class categorization, which I had picked up from 2021. That's a white paper that was published. So we can divide the patients into low risk, high risk, and very high risks. So low risk are the ones where all present fragility fracture. The DEXA score is between -1 and -2.5, and the FRAX 10-year probability is low. Such patients may require only calcium, vitamin D, and bone-friendly lifestyle. When we consider them to be high risk, anyone can be present. Presence of fragility fracture, DEXA score, which suggests osteoporosis, and if the FRAX probability has been found to be shown that it is at high risk. It is here, apart from lifestyle modifications, we consider the anti-resorptive therapy. And if it is very high risk, then any one of them, like recent fractures, multiple fractures, severe fractures, fracture while on treatment, fracture while on bone toxic drugs like corticosteroids, if T-score is less than -3, or if the FRAX score is even higher, that is when the hip fracture is more than 4.5. Such patients will require anabolic treatment. So I would like to end by saying that every health professional should inculcate in their routine practice to evaluate, at least initially screen every woman over 40 years of age to identify the high-risk factors by history, do a physical examination, and the least they can do is look at the OST score. And we should not hesitate to advise DEXA scan based on the indications of IMS, as well as if there are any of the high-risk factors in history, or if the OST score is found to be high. Diagnose osteopenia or osteoporosis based on the BMD, evaluate the patient clinically, and do the essential laboratory tests, do the risk categorization, and initiate treatment accordingly. So I would just say the gospel for prevention is that we need to maximize the peak bone mass in youth, maintain it into the middle age, and minimize the loss of the older age. that we can do it if infants are really prone and open to be able to detect osteopenia, osteoporosis at much earlier age. Thank you very much.
I would.
Okay.
Can I have a question here, Dr.
Yeah, yeah.
Jyoti, Dr. Shobha Gudi here? So
Yeah, Doctor.
I was just wanting to know premenopausal women. Premenopausal women. Did you come across when would you earliest screen them, and how would you uh, try and prevent if the osteoporosis scores are high? How will you prevent osteoporosis? Did you
So
come
if,
across? Because we are going to discuss that, but I thought I'll ask you since you have also gone through the latest research, etc. Yeah.
So if you're talking of premenopausal, we are saying that as early as 40, we should be start screening a woman.
Correct.
So
Yes.
screening women should start at the age of 40. Why we are taking 46, but even earlier if they've got any
Even
of the
earlier,
factors.
because I think if they are low BMI, etc., and family history, right?
Yes. On
Chronic steroid
glucocorticoids
therapy,
or yes.
or even severe hypothyroidism,
And
right?
even the
One
POI
more
patients, I
category,
They
Dr.
have
Shobha,
very
who are
POI
coming up
patients
is girls who are suffering from the different type of the cancer, leukemia and all.
Correct.
And with that,
Cancer
they,
survivors, cancer
yeah,
survivors.
cancer
Yeah.
survivor, they're increasing.
Because chemotherapeutic related
Yeah.
ovarian insufficiency might be there. They may be prone. They may not have attained menopause, but they may be in some stage of POI. I agree with you. Yes.
and even the POI
another
patients,
group
once we
is
diagnose,
Also, when lot of steroids have been taken by the patient, we have to keep it in mind, I think.
Yes. Correct.
and even for the POI patients, I think the moment we diagnose a POI, we should definitely do a DEXA scan because that will
Yes.
make a base for that patient so that we can evaluate them later.
Yeah. No, the complexity is less there because anyway MHD is indicated for them. We are talking about undiagnosed cases of POI here. That is where the problem lies. Okay, we'll come to it. Now I invite Dr.
No,
Anita.
one more, Shobha Gudi, there is one more indication.
Bolo.
Yes, that is the adolescents who are having repeated fractures. They are with already low BMD. So those are also indications for getting them tested because these are the ones who are entering the adulthood with a low BMD. So they are not even thinking about those family history, but personal history of fractures earlier in life. So they can also be.
Very right. So all the three speakers have covered the subject very nicely. We have one senior orthopedic surgeon, Dr. Nishit Sroff from Surat, who is a senior orthopedic surgeon practicing since 1985. Nishit bhai, tamaro video on karo. He is the president of Gujarat Orthopedic Association as well as he was the pioneer in South Gujarat Orthopedic Association. And of course, he is our member of Indian Menopause Society from Surat branch. So Nishit bhai, I would like to have your comments regarding osteopenia, osteoporosis, how you just give the preventive care or how you would like to treat, whether you are always treating osteopenia with which medicines usually you utilize?
Main thing is the counseling of the patient. We go in the detailed history of his lifestyle since childhood, how he has behaved, whether it is absolutely remained sedentary or there are some role of exercises in his life or in her life, and what is about his diet, etc. And then look for any predisposing factors, any disease, other, or if she is a menopausal woman, then whether there isn't any early menopause or there are some other factors or not. So we usually feel that if she is likely or he is likely to go for osteoporosis or osteopenia, then first insist on the lifestyle modification. And especially in women around the age of menopause, we also send them to gynecologist or recommend hormone therapy for immediate prevention of osteoporosis. Till the other factors, the lifestyle modification, dietary, nutrition, and yes, even the biphosphonates. These drugs, they take a lot of time before they actually work to prevent osteoporosis. Whereas this hormone therapy can immediately act for sometimes and then it can be withdrawn judiciously, and further treatment can be enhanced accordingly. So usually for prevention, it is better from the history of the patient and whether there was any fracture before they consulted us or not. So then the prevention is required. Otherwise, osteoporosis per se to become symptomatic takes a long time. Even in the postmenopausal woman also, not immediately it becomes symptomatic, or there are no immediate fractures as soon as menopause sets in and the fracture will start. No, it will not. It will take some time. So, but those who are having predisposing factors or are high risk, then we should think of giving preventive therapy.
Sir, I have one question. Suppose the woman is in a younger age group, like 40 to 45 years. They will tolerate bisphosphonates better if you consider the scoring to be high. Can we initiate on them on bisphosphonates? And for how long that therapy can be given? And can we also have hormonal therapy along with it? Have you had any experience of MHT in this age group?
Yeah, see, bisphosphonate when once tolerated is very safe. Number one, it once you start it, the aim should be to give it at least for 2 years continuously. And if you feel that the patient is not taking it, patient may the hormone therapy may be added as in for a synergistic action in case of a severe problem. See if there is an ovary loss or there are other predisposing factors, premature menopause. So that can be both the therapies can be given. The results are good with combination therapy also. But biphosphonate per se, one tablet, maybe they in the form of once in a month, is quite okay and well tolerated. So we prefer that rather than hormone therapy. But when we want to combine it, we often consult with a gynecologist and then jointly. So she will look after other causes also, and then can be given. But results are good for combination therapy also, and in younger age group especially. What you said is say between 40 and 50, hormone therapy works well. After 50, I don't know whether it will help much or not.
Sir, the bisphosphonate therapy, I just wanted to know the duration because these women are at
2 years.
risk because,
2 years, at least
sir,
2 years.
but menopause once they attain, then the risk of osteoporosis is rather enhanced only for them. They are already osteopenic, so progressive risk रहता है उनका.
See, as such, once osteoporosis is settled, this we are talking of prevention.
Yes, sir.
If the osteoporosis is already settled, then the therapy is lifelong with a disease-free interval in between.
But prevention recommendation is 2 years. After that, we
Yeah.
can assess and continue if
Yeah.
necessary.
So then we have to go for DEXA scan and look at it.
Yes, thank you.
One question, sir. Usually, orthopedician first choice is bisphosphonate rather than hormones, sir. Because I think it's because there is no age limitation like MHT only up to 60 years and so on. Whereas, as you say, bisphosphonate can be given at any age. Is it so?
Yeah, bisphosphonate can be given at any age, not in the children, but above 40 it can be given at any age. So there is no problem. But for hormone therapy, I think there may be some restriction and it should be rather under supervision of a gynecologist so that they can do other clinical examination also for developing some side effects or complications of it. I think Dr. Dalwadi is also there. He may also say something.
Yeah, we have
hello, hi.
very young dynamic endocrinologist from Surat, Dr. Pradeep Dalwadi. Currently,
Hello, ma'am.
the secretary of Surat Menopause Society also. So, Pradeep bhai, your comment?
See, when you are dealing with osteoporosis in a young patient, like as you asked me, a 42-year female patient, see, what is my preference is to rule out all the secondary possible causes of osteoporosis in a young patients. Okay. Now, if you're using for a prevention, if the patient is in a perimenopausal age or a postmenopause or early menopause, I think what I have gone through a recent data of hormone replacement therapy is really encouraging. Is really encouraging. And if you see by latest Korean guidelines, if you see a recent meta-analysis of hormone replacement therapy in prevention of osteoporosis, the data is encouraging. The data says that the bone gain, if you give hormone replacement therapy, it is 6 to 7% at lumbar spine and 4 to 5% at the femur. So if I am dealing with a case of premature ovarian insufficiency, like a premature menopause, and if the woman, I know that she is at very high risk of developing osteoporosis in future, and she is not having, I have ruled out other causes of osteoporosis in a young patient, and if she is definitely at risk, then I will definitely consider and I will prioritize based on the current evidence which we are having, that I will prioritize hormone replacement therapy in that patient, and I would like to give till it is possible with dynamic risk assessment. Let me tell you, no treatment is without ongoing risk assessment. Even if I'm giving a hormone replacement therapy, it does not mean discontinuation of the risk analysis. You need to annually or biannually, you have to assess the risk. And when you find that the density is deteriorating at the right point of time, we have to introduce an anti-resorptive agent or a bone formation agent. And then we can continue treatment based on the further risk stratifications. Okay. But yes, the today's talk is on hormone replacement therapy, and what the data I know, the data is really encouraging, particularly in young, just recently menopausal women. If they are not having classical sign of osteoporosis, and if you want to use this treatment as a preventive measure, I think now we are having wonderful data for that as well. Thank you.
I just wanted to ask whether you have any experience of SERMs, the selective estrogen receptor modulators.
See, truly speaking, madam, I don't use some in my practice. Okay.
Okay.
Once the patient is having osteoporosis, okay. As far as rightly said, I give a standard treatment of osteoporosis like bisphosphonate, denosumab, teriparatide, and recently I have started using
That
even
is the
ramotuzumab in
management,
some of the
I think.
patients.
Yeah. I think we have one more module to follow where we deal with the management of osteoporosis per se, and that time we will definitely require your help again, Dr. Pradeep. Thank you.
Yeah.
Thank you so much.
Thank you. Thank you.
Can Dr. Jyoti show again the OSTRA score? Somebody was asking.
Sure, why not?
Dr. Jyoti, please just show the OSTRA score.
We have distributed cards of OSTRA scores to be on the table.
A chart also.
Yes.
It's very easy to calculate on your mobile only. 0.2 weight minus age in years. And we have the next moving now. And this is how we can plot it on this and decide whether it's meeting or this. And the score normally comes at less than 0, more than 20, or between 0 and 20. So we all can sit and do first our scores and then use it with our patients.
Correct. Thank you.
With this discussion only, there's one more question anybody can answer. That is a patient with a osteopenia with endometrial hyperplasia with atypia. What will be your choice?
Without
You give
atypia
the
लिखा है
estrogen?
इन्होंने.
Would you give the estrogen or not?
इसको थोड़ा ले लेते हैं डिस्कशन में, है ना?
हाँ, ये जरूरी है क्वेश्चन.
हाँ, ठीक है, ले लेते हैं डिस्कशन में.
Shall we move on?
Yeah, we can move on.
Okay, thank you, Dr. Jyoti, and the experts for your comments and the presentation. I now invite our next speaker, Dr. Shobha N. Goody, for her talk on prescription writing with case scenarios for symptomatic and asymptomatic women. Now, to briefly, Mr. Paresh, can you please project Madam's CV? I can't do it from my end. To briefly introduce Dr. Shobha Goody, she is professor at St. Philomena's. I now invite our next speaker, Dr. Shobha N. Goody, for her talk on prescription writing with case scenarios for symptomatic and asymptomatic women. Now, to briefly, Mr. Paresh, can you please project Madam's CV? I can't do it from my end.
ये repeat क्यों हो रहा है?
Introduce Dr. Shobha Goody. She is professor at St. Philomena's. I now invite our next speaker, Dr. Shobha N. Goody, for her talk on prescription writing with case scenarios.
From 2 places, I think.
That's a technical error. It's okay. Madam, over to you.
Yeah, I think it's better to start.
Madam is also the co-director along with Dr. Ragini Agarwal.
अरे नहीं. I am just thankful for the opportunity to be involved in this because as chairperson of the endocrine committee, I felt that I must do something productive along with the central team. And I'm very grateful that I was given this opportunity to do it along with them. So is my screen seen?
Yes, ma'am.
So today's prescription writing is not going to be easy. It's going to be very tough because the guidelines. Hello? Okay?
Yeah.
So the guidelines are not very clear on this. So let us sit and kind of, come to some consensus or at least have some thought forward or at least decide to do something for these women who present to us. At least give them some medication for a brief time if we don't have long-term courage to prescribe long-term, at least take them through few months or 1 or 2 years of therapy so that the bones are better prepared for menopause. So a case only one will be discussed and we will just write the prescription for one case only. 44-year-old woman still having regular periods. She may, we will think about her as either asymptomatic or she may be having mild hot flushes. This will help us to kind of explore all the possibilities that we can prescribe for her. She is incidentally hypothyroid for the past 12 years with slightly increasing doses of thyroxine. The sister has had a hip fracture at age 54 and it was diagnosed as a fragility fracture. Her BMI is 18 only. She is a low BMI lady. And we have to think about what is her main risk. Of course, we put her through the entire assessment. We take her history in detail and also we do the Oster score for her. And then we come to the conclusion that she is group 1 or group 2 for menopause hormone therapy and she already has a disease. So let us focus on prevention of further deterioration of bone problem because her Oster score is already showing some moderate or risk or low risk or something. So we have identified here 4 risk. I think all the faculty kindly mute. All faculty have now kind of they are on board with me that she has 4 established risks of osteoporosis. There is family history which is strong. There is a low BMI. There is hypothyroidism, and she is also, of course, perimenopausal, and she may be having some symptoms already for estrogen deficiency, even though the periods are regular. We all know that that is possible. Now, the DEXA shows osteopenia. And incidentally, if we do find a normal DEXA, in this case, we must repeat it earlier than 5 years, maybe in 2 to 3 years. I've written 3 to 4, but probably we need to repeat annually or in 3 years because such a high risk of osteoporosis. Now, the exercise we will talk about a little more later, and I'll come back to this after the next talk. MHT we must consider in this patient. In this patient, we must consider MHT, if not now, in near future. And now, if symptomatic, that is what I thought that I will put it as, that she is still having periods, but she is at high risk of osteoporosis and fragility fracture, and she already has a positive Oster score. And also, if she is having symptoms, definitely she merits menopause hormone therapy even before she has attained menopause. We'll come to that. We'll come to that, and everybody can opine. As I already said, as far as evidence is concerned, this remains a gray zone, even though Indian Menopause Society and also the white paper released in last year in IMS conference also says that MHT can be given for prevention of osteoporosis. By bisphosphonates, friendlier in this age group. We have already heard the experts say that it is also better tolerated and it is indicated with precautions. There is a once a month ibendronate option and there is a once a year zoledronic acid option. Well, if the woman has some kind of serious gastric problems, then ibendronate will be difficult to prescribe. But by and large, oral bisphosphonates can be prescribed by us, or even parenteral can be prescribed by us under the umbrella of a multidisciplinary approach. Let us keep the umbrella open all the time. So this is the white paper. Everybody wants to kind of depend on this now, and which is not a bad thing at all. We must have some Aadhaar, some foundation on which to go forward. So there is good evidence that MHT reduces the incidence of osteoporosis and the risk of osteoporosis related fracture. And in some countries, for example, in that means they are talking about populations who are osteopenic, because they are preventing, they're talking about reducing the incidence of osteoporosis. That means they're talking about reducing the the progression of osteopenia to osteoporosis. For example, in US and Australia today, this is a primary indication for MHT. But this paper is still not clear whether they would consider it in a premenopausal woman or strictly only in a postmenopausal woman. We have to decipher that. So in this case, who is premenopausal and already osteopenic, let us explore the options very, very quickly. MHT remains an option for these women if they are symptomatic, recognizing that MHT is off-label in this phase of life. Considerably more research is needed. So what to do? MHT regimes for perimenopausal women, the sequential therapies are preferred, but with the knowledge that even sequential therapies sometimes called irregular bleeding, which we should be ready to manage. But sequential MHT is certainly one option. Another option in perimenopausal women who do not have contraindications is the conventional ethinyl estradiol based combined oral contraceptive, or the newer estradiol or estetrol based combined oral contraceptive. There are a lot of newer contraceptives, and some of them do contain estradiol, which may be more favorable for the natural estradiol, which may be more favorable for this woman. Then LNG-IUS is another very useful option at this time and can be used in combination with estrogen if MHT is required. So we must think of these options in this woman. That may also kind of answer the question which was put up in the chat box. LNG-IUS can be used if at all we are considering a very low dose estrogen. But then maybe it will be better to wait for reversal of the hyperplasia completely and then start her on estrogen therapy with an adequate progesterone cover. And LNG-IUS is considered as a very good cover. A further option could be a combine agonist or antagonist GnRH to suppress residual ovarian activity with add back MHT wherever we are concerned about endometriosis or fibroids, etc., because we do get women like that also. Then we could combine that. But then this is a little kind of off the track, so we'll not consider that. It was just listed there. One thing which I wanted to ask and I forgot actually was non-hormonal alternatives. For example, the neurokinin NK receptor antagonists, which can be used for control of hot flushes, but can they be used in women who have risk of osteoporosis is what I needed to ask. We'll go ahead. SERM is an important molecule for us. Though the orthopedician may not kind of cherish the thought of prescribing SERM, let us believe that SERM is an important tool for gynecologists to use, and there is enough evidence for the use of SERM. Now, selective estrogen receptor modulators, raloxifene at 60 mg per day is already established in postmenopausal women to reduce new fractures, grade A recommendation. And it can be used for prevention of osteoporosis also. But whether it is used in premenopausal women, again, I am not able to find the data. Probably if women are already showing some symptoms or a higher Osta score or other features of estrogen deficiency, then raloxifene to be used for prevention, but unfortunately it increases the hot flushes. So it may have to be combined with with some other MHT, which which can be looked at, and that combination is bazidoxifene with conjugated equine estrogen, which is a kind of universally accepted in the Western world. It is the first FDA approved medication as an option for vasomotor symptom plus prevention of osteoporosis. So bazidoxifene with conjugated estrogen, so far difficult to access in India, but it is a very, very valid option, this combination for prevention of osteoporosis in women who are requiring MHT at a younger age. Raloxifene and estrogen have a similar incidence of VTE. That is the reason we may not be able to combine raloxifene with estrogen whenever we are talking about hormone replacement therapy. But basitoxifene has not been found to be so. It is a higher molecule than raloxifene, more refined, and that has not been associated with this. But basitoxifene is also, in addition to skeletal, it also improves lipid parameters. And the question of its effect on hot flushes is questionable. It may benefit or it may not worsen. So, but it can be combined with conjugated estrogen and the molecule is available. So these are the thoughts on SERM. I just put it here because in case the woman is asymptomatic, because I said we must also consider a woman who does not have hot flushes. In her, around the time of menopause, raloxifene may be a good idea. This especially becomes a good idea if there is an increased risk of breast cancer as well, because raloxifene therapy has been shown to reduce the risk of invasive breast cancer by 76%. It's a grade A acceptance, and it has got a high benefit for prevention of progression of osteoporosis to osteopenia to osteoporosis. Okay, I just wanted to bring in here that all preparations, including low dose, non-oral routes of estrogen, are effective in preserving bone mass. So all estrogens are good, but in women with hypertriglyceridemia, obesity, diabetes, DVT, tobacco users, non-oral route should be preferred, and that is grade B. So in case our women are having any other high risk, we should go for grade B. Fortunately, the woman under question with us does not have these. So oral route can be considered as soon as it is feasible. The other thing which we have been discussing is MHT is a primary therapy to prevent bone loss in women with premature menopause and secondary amenorrhea, right? So POI. Now, before I think I go on to the final prescription, let me call in there is another speaker, isn't it, Dr. Lakshmi?
Yeah, Dr. Padmaja is the last speaker.
Yeah, so let Padmaja finish, then I'll bring in the last slide as a conclusion. Yeah, thank you.
Any comments? Thank you, Dr. Shobha, for a very nice illustration of that case scenario.
Yeah. So since we are running out of time, Dr. Lakshmi, I will just go ahead.
Okay.
Lifestyle management, how to individualize in women at risk of osteoporosis. So that was what I was told. All of you must have already got a gist about what I'm going to say because we were talking about the risk factors and all that. So lifestyle modification and intensive monitored program. There was a beautiful article that came out in Jan 23, and the work was done at Manipal Institute, where the physiotherapy unit had worked with the ortho and the gynec departments, and this was a very good article that they had done. And here they said, the most important thing is we keep emphasizing physical activity, but we should be adequately spending time on health education, because only when we have that good communication and continuous talking to women about how important this is exercise, that they will follow up on it. And along with that, diet and follow-up are necessary for the sustenance of motivation. So exercises should be stretching, and one of the easiest exercises that they showed, like, so when women come to us, if it say exercise, again going to a physiotherapist and doing all that, they might not do. So simple things that can be done practically by everyone with minimum supervision is a wall push-up, toe lift, sit in a chair and stand up, stepping up and down. So these simple exercises will increase the flexibility and mobility. So just 4 things. So we can ask them to just stand and sit in the chair right in front of us. So then they'll realize that exercise is so simple. It does not mean that you have to have a gym membership and a personal trainer. And when these were done and followed up, the exercises, what they found was that when intervention was done, the BMD, which was as low as minus 2.2, had come down to minus 1.3 with diet and exercise at the end of 3 months. And at the end of 6 months, it was minus 1.5. So balancing exercises are also very important because these can limit the fall of risk. So not only do we do stretching, we need muscle building, and we need to get them to start using these balancing exercises. So for that, stand on one foot, stay for a moment, stand on the other foot. So that itself is very good exercise. And Mediterranean diet has a positive impact on bone health. So anything that is having whole fiber natural food, starting with the food pyramid with lots of colored fruits and vegetables, dairy products, and less of processed food is good for the health. And whenever we have a highly westernized diet, there is low fiber in it, and this not only leads to low calcium and vitamin D in the diet, but it also leads to a low grade chronic inflammation that causes osteoporosis. It leads to change in the gut flora, where the microbiota that are there change, and most of the absorption and of the vitamins, vitamin K, happens from the gut flora. So taking calcium and vitamin D supplementation is also a very good measure, because the World Women's Health Initiative looked at 36,000 postmenopausal women, and they said 1,000 milligram of calcium with a 400 IU of vitamin D supplementation is good, although it does not, we will not say that people who take it will never have a hip fracture, but when they strictly follow the schedule, they are less likely to have a hip fracture. And as was told in the last month webinar, calcium only 500 milligram can be absorbed. So 500 milligram needs to be split as twice a day. If you give 1,000 at a time, it is less efficient. Magnesium is one of the things that is necessary for maintaining the bone health. So 422.5 milligram magnesium, they have a slightly higher BMD. So magnesium is available in all the nuts that we have. And after COVID, everyone is conscious about diet, taking nuts. So encourage a few nuts every day. And one more thing is, we need to talk to people about changing the environmental risks. So make sure that they don't have loose rugs lying around. The stairs are not really with glossy stone. They have good handrails. The bathroom floors are not wet all the time. They should have a dry and a wet space in the bathroom. Adequate lighting in corridors so that they don't bump into things and fall down. So these modifications are, and handrails wherever they are necessary. So these will decrease the risk of fall and decrease the risk of having a osteoporotic fracture. And one more important thing that we don't really concentrate on is on stress, because whenever there is stress, there is increased reactive oxidative species, serotonin, corticosteroids, insulin-like growth factors, and all these lead to systemic inflammation, which causes more osteoporosis because of osteoclast differentiation and apoptosis of the osteoblast population. So to conclude, whenever there is a good exercise program, taking a healthy diet, including exercise in their daily activities, some amount of weight bearing, they can simply pick up water bottle 1 liter and keep doing this for their shoulder exercise. Have a water bottle 1 liter in each hand and walk up the stairs. So simple exercises like that will help. Taking supplementation, having a regular diet, a regular screening program with a stress management program will help most of the women take care of preventing osteoporosis. And this is the sort of exercise and advice we should be giving to women who are at high risk. Thank you very much.
Thank you, Dr. Padmaja. As always, exercise should be
Excellent.
prescribed like a medication.
Very crisp and very short and very concise. Excellent.
Comments, please.
Dr. Shobha needs to finish her prescription.
Yeah.
Oh, we are waiting for that.
Little trouble with the laptop. I don't know what has happened. It has got stuck.
As we are waiting
I
for
think we
Dr.
should
Shobha
finish
to
it off
talk.
in 5 minutes,
discuss.
please.
I will just quit on the laptop and I will rejoin there.
Just a question,
But I am
actually,
here on this.
Dr. Ragini or anybody, how important is magnesium in the diet, which is so highly
that's what-
publicized these days? Because
That is
I
what
just
I
like
was
to have
planning to talk about. Magnesium is very important for bone health. We should take it. We are all the time talking only about calcium.
Yeah, that's what.
Taken in the ratio of 2:1. That is calcium, 50% magnesium. Both should be taken for a good bone health. That's
No,
the must.
calcium, magnesium help calcium
Hello,
to
is
work
there a
and
problem?
perform properly. Even there are certain pure magnesium tablets are also available.
Yeah.
They are really very, your pharmaceutical magnesium sulfate, magnesium tablets, they are cheaper than what is on the Amazon with the boutique magnesiums, which is
Okay,
given by all nutritionists or
Yeah.
physiotherapists to the patient.
Yeah, just बोलिए Ragini.
And very, very helpful for the cramps.
Yes.
Yeah, very, very much. What about
Very
vitamin K? Vitamin K?
Madam, if we
Also
have a
needed for
good
proper
gut
calcium
microbiota,
absorption.
we don't really need vitamin K because it is made in the gut. So that is the reason why we are encouraging women to make sure that they have a high fiber, low glycemic index diet with all the colored vegetables that are there. So because that makes sure that the gut flora that we have, because we've evolved with the microbiota in our gut, and it is a nice relationship that we share with them. So we give them food, they give us the vitamin K. And so unless, I'm not very sure that we should be recommending vitamin K. So we should be encouraging them to eat.
I'll just share some data which says that we must. Give me a minute.
Yeah.
And can you give some examples of low glycemic index nicely?
Anything that tastes good has a high glycemic index, madam. So anything that is white, anything that is processed will have high glycemic index. Because what happens is when we polish, we remove off all the fiber around it, so it comes out looking pure. And that is how it turns immediately. It is absorbed, it is digested very fast, and it turns very fast into glucose in the blood. Can you imagine if we drink sugar, it's 100, and if we eat white rice, it is 85. Brown rice is 84. So eating rice itself has that. So it is the millets that are 27 in the glycemic index. So if we really need to change, we need to shift to millets, because even wheat has as high as 75. We keep thinking that we are not eating rice, but all these will help. And all maida, white bread, so whatever is white, so all the colored ones
The
will have
whites.
less. So that is the easiest way I find to say, rather than look up everything.
And
And not
anything which is
only
eaten
we
raw.
should not forget
I
that
have
rolled
just-
oats, which is very popular in our youngsters, that oatmeal. This rolled oats, which is an instant thing, is also also equivalent to the maida. Then your cornflakes, here again the maize powder is totally processed and rolled into the cornflakes. All those muesli.
How to
And
search for the
we
Google?
tell the patient the
It's not
glycemic,
coming in this.
high
Apps
glycemic, we have
albarata,
to
ella
give the
barata.
examples like this also.
Padmaja, increasing the protein intake
Song?
can it help? Padmaja? Increasing the protein intake.
But it's not Chrome.
Yes, madam. Increasing
Chrome ಇಲ್ಲ ಅಂದ್ರೆ
protein
mostly
intake,
ನನ್ಗೆ
basically
ಆಗಲ್ಲ.
what it happens is
Chrome.
It reduces the
I don't
absorption
know.
of the carbs. No?
and not only that, it
No, I have
gives
to
more
present
satiety.
something.
So,
I have to-
and what happens is
It's there.
proteins go as amino acids, And when our blood sugars come down, there is
He has promised me that he's going to change.
the extra carbs floating around, when we don't need it turning into being stored as fat, proteins are a healthier option. And the thing is, smaller quantity we will take protein compared to carbohydrate, and it leads to a more satiety, and the tummy feels fuller for a longer time. So proteins are good, but I wouldn't advocate again protein shakes, because anything that is processed is never ever balanced. So in natural form,
I'll just check
in
if
our
the
traditional
presentation
foods,
is not
whatever is
open.
there is good.
Yeah, so my problem got sorted. I'm just joining. Just give me a second. I've joined. I'll just.
One thing important is that osteopenia and sarcopenia, they go hand in hand.
Yes.
By the same time, they are going.
Yeah,
So we
so
do
and,
need proteins. Proteins, Padmaja, as you said, we do need proteins about 1 gram per kg per day.
And Indian diet is very poor, madam, because we don't consume that 1 gram per kg body.
That is there. No, that is there. All these millets, they have good proteins. All these bajra and ragi and everything they have. And then paneer has a good protein.
Okay, so if everybody is on board, I will just kind of revise whatever we discussed so far. So this is am I audible?
Yeah. Yes, ma'am.
Yeah, fine. So MHT prescription for, I'm talking about premenopausal women with risks like Osta is moderate and high risk, or even, I don't know if low risk can be managed otherwise. But then let us think that there is a higher risk in this case. So suppose the woman needs contraception, we can consider in symptomatic women even low dose oral contraceptive pills, combined oral contraceptive pills, according to MEC criteria. If you follow the medical eligibility criteria, we are not going to go wrong in that. And if symptomatic, the other option would be insert an LNG IUS for the contraception, and then we can use transdermal estradiol or even oral estradiol, or we could go for sequential estradiol plus dydrogesterone, which is sequential, which we are all used to using by now. So sequential HRT, MHT can be used in women who are symptomatic and do not require contraception. Now, if they do not have any hot flushes, but they are at moderate and high risk OSTA, we can use raloxifene. Now, all these options of hormone replacement therapy in premenopausal women are yet not evidence-based, though people have started talking about it. So we need to carefully individualize. And as far as the SERM raloxifene is concerned, this has a venous thromboembolism risk equivalent to estradiol, as I said already. So we need to carefully rule out that individual cardiovascular risk factors for venous thromboembolism, and we can prescribe because it is very highly effective for prevention of osteoporosis. Now, if they are symptomatic, if the same woman is symptomatic, she's got a high risk osteo score, she is symptomatic. The other option in women who do not require contraception, I repeat, they do not require contraception, is the bazidoxifene and conjugated estrogen combination, which is available in the West. This combination actually is hard to access in India. It may not be available, but it seems to be the answer for those women who are symptomatic. That means they require some estrogen, and at the same time, they are at risk for progressive osteopenia and osteoporosis, because bazidoxifene has an extremely good effect on bone conservation. And then we come to bisphosphonates, for which there is a lot of emerging data today that it can be used in younger women. So we can think of the once a month oral ibandronate or once a year zoledronic acid. I was speaking to one of the orthopedicians in Bangalore, who is actively managing cases of osteopenia and osteoporosis. And he was telling that his preference is once a year zoledronic acid. And we had the same opinion from the faculty who joined today. So do identify your women who have high risk of osteoporosis or already osteopenic, have a high, moderate to high risk. We can consider bisphosphonate therapy with multidisciplinary approach, or we can also consider something like raloxifene if we are carefully individualizing the case. If they need contraception, we can go ahead in symptomatic women with low dose oral contraceptive pill, applying the MEC criteria. Or we can, even if they don't need contraception, we can consider transdermal or oral estradiol with LNG-IUS. Or if they don't need contraception, we can see if they are suitable for sequential. So this will be falling within the window of opportunity approach for MHT, where women has not yet approached, attained full menopause, but also already showing the symptoms of menopause or showing a positive Oster score. So possibly now our mindset has to change to accepting a positive scoring also as estrogen deficiency. And then we must try, because some women may not get hot flushes with estrogen deficiency. We must try to replace in a very, very guarded manner. So that requires clinical nuancing, skill, and individualization. Exercise, I think Padmaja has nicely told about exercise. But as she said, aerobics, resistance exercise. So all of us should encourage them to have resistance bands at home, the different kinds, and also some weight bearing exercises. Dancing is a wonderful one, as well as stair climbing. Any anti-gravity exercise will benefit them. There has been good discussion on diet and calcium intake. I just wanted to highlight here that I will not be very happy with 400 international unit of vitamin D per day. This woman definitely, I'm sorry that it is typed as 1,000 units here. It is 500 to 2,000 units, which is this range of vitamin D per day is appropriate in these women. And then I must say that we must all look at the vitamin K supplementation. Even though we talk about good microbiota in the gut as source, let us remember that there is a grade C recommendation for vitamin K27 intake in these women, midlife women, because it gives both bone and cardiovascular health of women with osteoporosis would benefit from this. So bone health as well as cardiovascular health benefit is there. So I rest my case here. I think this is what we have been able to achieve from today's discussion. And I would like to just say that though I formulate a prescription, I depend also largely on the inputs that I get from the discussions which happen here. So it's a kind of live prescription writing. So today I have made an effort to bring in the possibilities of MHT even before the woman attains menopause. I only wish Dr. Meeta and Dr. Jyoti Unni and others who have worked on the guidelines were here, but unfortunately they were very busy. So next time, Dr. Ragini and Dr. Anita, when we do part 2, we shall take in all those who have made the guidelines. I think even Sudha, I'm not able to see now. Sudha is there, yeah, Sudha is there. So now we can conclude with a few expert comments. Thank you for the patient listening.
Thank you, Dr. Shobha. Just a query. Would you be estimating vitamin K deficiency and then prescribing, or do you just
No, that is not what has been recommended. It has been thought that they do benefit. They do benefit with the supplementation.
So
that is what has
empirically
been.
taken.
Yeah, it is taken. They benefit with the supplementation. That is what the evidence is saying. But it is possible that this data is from Caucasian women. So I need to look this reference up again. I was not able to find it. I will need to look it up again, and
So
we will start sharing.
And what is the preparation?
Yeah, we must.
Yeah.
I do remember
Madam,
some industry partners coming and telling about oral vitamin K. I do remember in midlife women.
Okay.
So it is not that the preparations are not available. They are available.
It is available. Amazon have everything. But I don't think, as Padmaja has
K27,
said, very rightly said that we don't require vitamin K as such. It's better to promote our
थोड़ा और
gut
पढ़ना
health.
पड़ेगा. I think.
And
But then also, Ragini, of late, the mid-gut dysbiosis has really gone up. The incidence has gone up.
You know, there's one problem which I think it is the biggest problem. The use of jet during your body. What happened? The people are getting more, the women are getting more and more of the UTI. You are giving them antibiotic, and this cycle is really destroying your gut.
Yeah, I think.
It's
and IBS is a fairly common symptom, I feel, for midlife women.
Yeah.
Madam, there are some people who have an increased carotid score. So it's a screening test for carotid artery when the cardiologists do it.
Yes.
So in those people, they say they have calcified carotid. So where we should not be using calcium carbonate per se. So in those group of people, they say add vitamin K, use calcium citrate maleate, because we don't know whether they're going to die of a stroke or they're going to fall and die of a fracture. So you have to weigh both the balance. But in those,
you're really frightening me, because we are all recommended carotid Dopplers. Yeah, we are recommended carotid.
So,
whoever has high plaque score in the heart are recommended carotid Dopplers.
So for them, calcium carbonate is not the salt of preference. So in them, adding another salt with K2 might be beneficial. That is what
we will look on this a little more and get back in the next session.
The other thing that I understood was calcium in therapeutic doses does not produce calcification.
It does not. No, it does not contribute to the plaque formation.
Calcification.
One thing.
No, but she is talking about specifically about carbonate as against citrate malate. So we need to, because some studies say that, some do not. So we need to really get to the bottom of this.
So I want to add one thing. Most of the PCO patient, and then your menopausal metabolic syndrome. Metabolic syndrome, when we talk about the metabolic syndrome, we have to think that these women are suffering from the atherosclerotic plaque mostly. So this is a big group nowadays, not a smaller group.
बहुत ज़्यादा metabolic syndrome and atherosclerosis.
Yeah, where
and
we have
high
to think on
LDL.
the atherosclerosis, because this
Diabetes,
is the bigger reason
glucose,
for the
insulin
silent
resistance. Yes, it is.
And madam, in postmenopause, they were going to be more hyperandrogenic because they have a theca which continues to last.
Yes.
Their follicles are gone.
They have higher risk of cardiovascular events, undoubtedly. So they will require more. So I think that.
Any comment from your side from the east? Because we don't have any people here from the east.
Good evening,
Mamta.
फोटो
है बस यार फोटो का बड़ा
Good evening. I just want to think, madam.
Vipasha had joined actually.
Where's the Vipasha?
Good evening, madam.
बोलिए.
I just want to know one thing. Just if teriparatide is given to a patient with osteoporosis, and then we know that it can be given for 1.5 years to 2 years, can this be repeated after the course of some other treatment like denosumab, or this is the only can be present once in a lifetime?
ये तो next session में करेंगे treatment of osteoporosis.
Okay.
But I think it is possible to repeat from what I have seen, and because life will go on for so long, so definitely it may require repetition.
So they have all these called sandwich therapies, madam. 2 years they use that, then they will add another molecule, and then they will bring back.
So that is what Dr. Kurupad was telling me, that giving once in a year zoledronic acid actually kind of fits in the theory with a drug break. That's what he was telling me. Because that the effect may not be full 12 months. So if you repeat it annually, it fits in with the principle of giving a therapy break also. That's what he was telling me. So possibly in women at higher risk, we must seriously consider giving them zoledronic. Otherwise, they'll progress and become osteoporotic very fast. This is what I wanted to.
Now?
Yes.
Thank you.
Thank you very much. Thank you. This was a little hard one. The next session will be much easier where there is already osteoporosis. So कुछ नहीं कर सकते उसमें. By recommendation MHT देना
I
ही
think
है.
सबसे पहले तो
And-
यंग एज वालों को समझाना पड़ेगा कि कोल्ड ड्रिंक के साथ साथ खाना मत खाओ.
Both
The
are bad,
bottom line
madam.
is-
ये fried
bottom
food
line
खाना is bad, cold drink is even bad.
They are damaging their skeletal system like anything.
And nowadays, the nostalgia cases are increasing very much, and caffeine is one of the factors which
गीता जी,
increases.
let's have a आज ही मेरे को दिमाग में आ रहा था कि एक सोशल वेबिनार करते हैं दादी से पोती तक.
कर सकते हैं. There is scope. Chalo.
Okay,
I
thank
think we
you.
must
Okay,
take
जी.
leave.
Okay.
Thank you very much.
Okay,
Thanks a
Okay,
lot.
so there are no more
Vote
points.
of thanks बोलना
Yeah,
है.
just an
Treasurer है तो.
official vote of thanks. Yeah.
Yeah,
We would
please.
like to thank all our esteemed dignitaries, our President, Dr. Anita Shah, all the esteemed faculty and delegates for having stayed with us till the end and for having an active discussion and wonderful participation. So it's goodbye from us until we see you again next time. Thank you all once again.
Thank you, all
Excellent
delegates.
session.
Thank you.
Thank you. Thank you.
Bye-bye.
Thank you,
Thank you.
Revati.